I will now turn this call over to Natalie Foster. Please go ahead.
Good afternoon, everyone. My name is Natalie Foster, and I'm a senior analyst in the Maternal Child Health Team at the Association of State and Territorial Health Officials, or ASTHO. And I'm excited to welcome you all to our second ASTHOConnect of Year Two for the Opioid Use Disorder, Maternal Outcomes, and Neonatal Abstinence Syndrome Initiative, or OMNI learning community. We're thrilled to have you on today's webinar. Please type your state name into the chat box so we know which teams are on the call today. I'd also like to take a moment to thank our partners at CDC's Division of Reproductive Health and National Center for Birth Defects and Developmental Disabilities, as well as HRSA's Bureau of Primary Healthcare for their continued support on this project. Today's webinar is on engaging primary care associations and leveraging federally qualified health centers. PCAs and FQHCs are important partners to engage in addressing the opioid crisis because of the role they have in providing comprehensive medical and behavioral health services in communities throughout the United States. First, we're going to hear from Dr. Sue Lin from the Health Resources and Services Administration, who will provide the federal perspective on the role of primary care providers in OMNI-related work. We will then hear from two community health centers, Scott Constantini from the Wright Center for Community Health and Jessica Cram and Dr. Sean Buck from the Lowry Center at Denver Health, who will be discussing the role of their respective health centers in providing services to pregnant and postpartum women and infants affected by opioid use disorder. We will then hold a Q&A after our last speaker, and ASTA will provide some upcoming highlights for the learning community. The objectives of today's webinar are to provide an overview of the federal perspective on engaging primary care associations and leveraging federally qualified health centers in the provision of services for pregnant and postpartum women and infants affected by substance use disorder. We'll also highlight two FQHCs and their role providing services to pregnant and postpartum women affected by opioid use disorder and infants prenatally exposed to substances. I'll now turn it over to my colleague Taquam to introduce our first speaker.
I'm thrilled to introduce our first speaker, Dr. Sue Lin. Dr. Lin is the Director of Quality Division in the Bureau of Primary Healthcare at the Health Resources and Service Administration. Her full bio is in the document sent out in the calendar hold. Please type your questions for Dr. Lin into the question and answer box, which will be accessed from the bar at the bottom of your screen, and we'll answer the questions at the end of the presentations. Dr. Lin, please take it away.
Thank you so much to the ASTHO staff for the invitation to present and spend a couple minutes with you at the beginning before we get to the meat of the presentation, at least the way I like to call it, where the folks from the field are sharing with you all their promising practices. Next slide. So I have the privilege of being the Quality Division Director and working in the Health Center program. One of the main missions of the Health Center programs is increasing access to primary care, comprehensive primary care across the entire country. In 2018, this is an infographic that we put together upon the release of our data that talk about the impact and the reach of the Health Center program. So in 2018, more than 28 million Americans received primary care at a HRSA-funded health center, which represents about 1 in 12 individuals. We have a significant pediatric population that we serve, 1 in 9 children, 1 in 5 rural residents, and 1 in 3 living in poverty. Within our legislation, we also have special populations that we serve. Those who are our agricultural workers, individuals experiencing homelessness, and residents of public housing. In more recent years, we have formed stronger partnerships with the Veterans Administration in order to provide services, primary care services for veterans within their community instead of them having to travel long distances to receive care at VA centers. And so we've been tracking and really pleased that we've served more than 385,000 veterans. And then, you know, we have a presence also at the school-based health center supporting pediatric health with more than 800,000 pediatric patients served at school-based health centers. Next slide. I think, you know, setting the stage for today's content and the reason why we have engaged in partnership with ASTHO and the Centers for Disease Control and Prevention is that we had seen a surge of opioid use disorder prevalence go up within the pregnant women population, and wanted to see what we can work with our public health partners in supporting primary care and public health integration. We started to support, make significant investment in behavioral integration back in 2014, when we've been tracking that with implementation of screening, brief intervention, referral to treatment, as well as the availability of mental health services built into the health center program. And so in 2018, Health Center provided over 10 million mental health clinic visits. Our workforce has grown significantly in the course of 2017 to 2018 by 10%. And that in terms of within the clinical quality improvement space, we had introduced the depression and screening with follow-up clinical quality measure back in 2014. And we've been monitoring that, and that has risen from 38.8% to 70.6%. But you know, the process of supporting our health center with technical assistance continues. So the strategies in which we were looking to support integrated behavioral health service in 2019 and 2020 is highlighted in the bullets in front of you, with a focus on clinical strategies addressing behavioral health needs of special populations, including women of reproductive health age, as well as enhancing behavioral health capacity in health centers through sharing promising practices. The things that we have focused on in our training and technical assistance that are related to the work that you all are doing includes expert depression screening, trauma-informed care, as well as looking at always to our health centers for the promising practices that they're implementing around maternal depression, substance use, suicide prevention and treatment. Next slide. In the substance use disorder space, in 2016, you know, in our efforts to address the opioid epidemic that has affected our communities that our health centers are situated in, we have provided additional funding and support to expand access as well as workforce capacity and clinical care for patients with substance use disorder. And so you'll see here that we talk a little bit about the increase in workforce of 23% from 2017 to 2018, and then the nearly 1.5 million clinical visits supporting our patients. In 2016, we also started to collect data on the availability of medication-assisted treatment capacity that we were building, both from a patient service perspective, as well as increasing capacity of the primary care physicians, the nurse practitioners, and the physician assistants that have data waiver. And we've seen significant growth in both of those areas, as you can see from the data slide. And then you know, as a core mission of a health center program to increase access and increase care, you'll see the steady increases from 2016 to 2018 from the bar graphs. We also continue to support training and technical assistance. Our connectivity to ASTHO is a key part of sort of the partnership and collaboration strategy that we hope to be able to mobilize and support across all the communities that we serve. And we're delighted to be on this call with you this afternoon for that. Next slide, please. So this is the most current behavioral health technical assistance investment that we have. And we have really built it around a learning health system approach. And some of the folks that are from the primary care associations will be familiar with a learning health center system where we are creating an implementation science system in which we can have know as interventions are being implemented, be able to do continuous quality improvement, learn from it through various plan, do, study, act cycles in order to continue to improve, because we know that as the community changes in their needs, that we need to be rapidly responsive to that. So within the Center of Excellence for Behavioral Health Technical Assistance, we have built an emphasis on primary care integration, how to support the workforce within health centers to advance this work. We know that there is an important service to system coordination piece, and that's why the state teams that are part of the ASTHO OMNI projects are incredibly important about how to do coordination better, and how primary care services can speak to public health systems better, and then supporting health center primary care teams with clinical workflow and health IT informatics that will really support their work moving forward. And we've just shared a list of some of the requested topics from our health center community. They're very interested in continuing to learn about the implementation of medication-assisted treatment, telemedicine, pain management, continue to enhance behavioral health integration service delivery. Next slide. A little bit about sort of where we are in terms of the prenatal care patients that we serve. We serve about just over 500,000 pregnant women in 2018. And we track this early entry into prenatal care clinical quality measure as part of our clinical quality improvement efforts. And these are some of the strategies in which we are continuing to enhance collaboration integration among health centers and home visiting programs in the supporting the maternal and child health space. Next slide. So I think, bringing it back to the PCA partnerships, the PCAs are our state level technical assistance partners in supporting our health centers within their states. And we're so excited to have this opportunity to have PCAs part of the state teams of the OMNI project. The role of their engagement, their connecting you all to the health center community within the states is incredibly important to us. I think, the places where we have partnered with the PCAs are listed here: accelerating value-based care delivery, which is a key driver for primary care right now, and helping health centers understand where they need to be in value-based care. Increased access, I've emphasized that throughout my presentation about that being a core mission of the health center program. And then PCAs are our state level partners in strengthening the health center workforce, enhancing the health center's readiness and preparedness for emergency preparedness. And then, as I've talked about the clinical performance and improvement space, that there are key partners in doing that as well. So with that, let me turn it back to Taekwon, and happy to entertain any questions that you may have later on.
Thank you for that excellent presentation, Dr. Lin. I will now turn it over to Scott Constantini. Scott is the Director of Behavioral Health at the Wright Center for Community Health in Pennsylvania. His bio is also in the document in the calendar hold. Please continue to type any questions into the question and answer box after the presentation. Scott, please take it away.
Thank you. I appreciate it. So first, I just want to say good afternoon to everyone, and just want to say thank you for allowing us to talk about some of the things that we've implemented here at the Wright Center around opioid use disorder. So a little history here at a glance about the Wright Center. We've always operated as a level 3 patient-centered medical home. This past summer, we recently were designated as a lookalike, an FQLA. So we've always integrated and tried to integrate primary care and dental and behavioral health, and most recently, I'd say over the past 4 years, addiction medicine. We also treat individuals in our infectious disease program, and we also have school-based services in a lot of the local schools. The Wright Center is also a graduate medical education safety net consortium, and we're doing a lot of training with our residents, and most recently we're proud to say that we have 22 psychiatry residents rounding through our clinics and throughout our community, and we are now applying for an addiction fellowship program. So we're excited about that as well. Next slide, please. So, this journey all started in 2016, and a little history on how the Wright Center kind of got involved in addiction services. Our CEO, Dr. Linda Thomas-Hemak, actually had a patient that she was treating that she became very close with, and she was doing a lot of very important work with this individual, and this individual had overdosed in between awaiting a long-term placement. So 2016, we became a Pennsylvania Opioid Use Disorder Center of Excellence, which, we are very blessed and grateful for that the state of Pennsylvania awarded us with that. And that was kind of the seed that was planted within our walls to really start looking at the needs of our communities and what we could do more as a primary care service line to expand medication-assisted treatment throughout our community. To date, we have 22 waivered providers within our system. I would say that's about 95% of our providers. So we have several new providers we just brought on that are actually in the process of becoming waivered. Our goal probably by maybe the end of February is to have about 30 waivered physicians. We are also fortunate that 3 of our medical leaders are sat for their boards and are board certified in addiction medicine. So since 2016, I think it was mid-February of 2016, we saw our first medication-assisted treatment patient. We've treated 739 patients with OUD. So in 4 years, I think that we've been able to accomplish a lot around the expansion of medication-assisted treatment. Next slide. So this is kind of one of the things that we're most proud of. So end of 2017, we attended a symposium in our state's capital, Harrisburg, and there was a breakout session from the University of Pittsburgh, the Women's McGee program, that did an educational session on what they were doing, and it kind of caught my my attention that we had a lot of pregnant moms who were struggling with OUD within our region of the state that could have benefited from a more tight wrapped service line. So we started talking about the development of the Healthy Moms program. So we actually went out and we visited the University of Pittsburgh and got to spend 2 days with them and really look at what they were doing around moms who were struggling with OUD. So we kind of put our brains together and got some other collaborative community partnerships with with Maternal Family Health and our local county drug and alcohol office and some other community resources, and put the Healthy Moms program together. So since 2018, we've had a total of about 82 moms that were served in that program. The 54 moms that we currently have in the program are active and doing well, and they're wrapped with certified recovery specialists, healthy mom case managers. They're having a lot of frequent and intense weekly touch points with their team to date, and that is up to December 31st. It's 38 babies, and I apologize. That really should read 43, because by the end of January of this year, we had 43 babies born to that program. So I think that this is probably one of our proudest moments in the Wright Center, to develop a program that is specific around moms and infants who are struggling with OUD. Next slide, please. So one of the things that we're also very proud of is that we are able to initiate warm handoffs pretty quick. In fact, a lot of our warm handoffs, I wouldn't even call them warm, I would call them extremely scalding or hot, because we have a lot of our resident physicians who are rounding in our hospitals, constantly calling our team to come to the hospital to have a conversation with an individual who is struggling with opiate use disorder. Maybe it's over an OUD-related hospital admission. So we've done a lot of work, and we're still doing a lot of work with our local hospitals to try to expand MAT services within our hospital systems. We've done a lot of education with the hospital teams, and we've also done probably a handful of didactics in the hospital system, grand rounds, to educate the hospital staff on OUD and what we're doing within the Wright Center. Next slide, please. So I think, we've done so much expansion over the last 4 years. Sometimes it's moving very fast, but we could not do this without the support of Pennsylvania. Key players within Pennsylvania, Governor Wolf, Secretary Dr. Levine, Secretary Miller, Secretary Smith at our Department of Drug and Alcohol programs, as you could see on the slide, I mean, there's just a lot of money that has been given to the Wright Center, which we are very appreciative of, to start these innovative programs to help individuals within our community here in northeastern Pennsylvania. Recently, we have also tapped into some federal grants. As you could see, you know, we received the USDA Distance Learning and Telemedicine grant for almost $500,000, an expansion MAT opiate response grant through HRSA, which is 3 years, and most recently, a grant that we applied for in 2018, we just recently, 3 weeks ago, learned we received through SAMHSA through the MAT PDOA expansion. So we have a lot of work to do. I think one of the things that we talked about in the previous call was that we have been very successful in recruiting and data wavering our physicians. And a lot of people ask us, you know, how have we done that? Because there are other systems that struggle to get their providers data wavered. We really don't make it an option. You know, if you were to talk to Dr. Thomas, our CEO and president, she would say, you know, that, you know, we have to be a part of this solution as medical professionals, and that if you want to work at the Wright Center, then we want you to become MAT wavered to be a part of the solution. And you know, we never want someone to walk through our doors in the here and now and be refused services because we didn't have an MAT wavered physician working that day. So we are proud of that, and we are going to continue to expand, you know, our providers' waivers. And, you know, I think that, you know, one of the things about the Wright Center is we are not afraid to take chances and, you know, really be innovative around this crisis. So, again, I appreciate the time to talk a little bit about some of the things that we're doing here at the Wright Center. And if you have any questions, please don't hesitate to ask. And I'm going to pass it back off to Taekwon. Thank you.
Thank you for the great presentation, Scott. I will now turn it over to Jessica Cram and Dr. Sean Buck. Jessica is a licensed addiction counselor at the Laurie Family Health Center at Denver Health. And Dr. Buck is a family physician at Denver Health as well. Both of their bios are included in the calendar for this webinar. Please type any questions for either Dr. Buck or Jessica into the question and answer box, and they will be addressed after their presentations. Jessica and Dr. Buck, please take it away.
All right, can you hear us now? Hello?
Hi, Jessica. Yes, we can hear you perfectly.
Okay, great. If you could go ahead and start the slides, that would be fantastic. All right, so some things that we wanted to talk about today were just the way that we integrated the addiction counselor into an FQHC. And then we actually have to talk about a case that we had here that we followed from 2018 into 2019, which was our first OB MAT patient. So we plan to follow out the presentation with just a case study about treatment outcomes and kind of both sides, the medical perspective and the counseling perspective of the whole case as we treated the patient. Next slide. Next slide, please.
Hi, Jessica. Are you still there?
Yes, can you hear us now? Hello?
Yes, we can hear you now. Apologies. Yes, we can hear you.
Okay, all right. So next slide, please. Okay, so in 2014, I came to Denver Health as the first addictions counselor to come into primary care, into the FQHC setting. And so it was definitely very new for me and very new for the medical providers to have someone who wanted to talk about addictions. Actually, I was told that there wasn't enough addiction to keep me busy, but they were definitely wrong. So I've been here since 2014, and the clinic continues to grow. And so now we work both on the medication and the behavioral piece all in one here at Lowry. For the medication piece, we not only do the inductions here in clinic, but we also follow them all the way through the maintenance phase until they're ready to taper. And the goal with the medication that we prescribe is to stop the opiate cravings, to block any symptoms of withdrawal, as well as obstruct the effectiveness of the opiate use, including heroin. And then the behavioral support is the addiction counselor, and then we do encourage peer support because it is an important part of the recovery process, but it is not a requirement. However, it is a requirement for them to meet with both the medical team and the behavioral health support. Next slide, please. So some things to take into consideration when you're looking to treat someone with an opioid use disorder is to, not only look at their interest in treatment, but really understand the risks and benefits, because at the FQHC setting, we're the least restrictive level of treatment, and there are times when folks just don't meet the criteria to be safely monitored in an FQHC setting. And then another area of concern is pregnancy. So during an intake, if the patient presents and doesn't know if they're pregnant, we always get a pregnancy test at the very first visit. And we offer them a referral to a specialty clinic. But some of the barriers with that is travel, distance, and some patients just feel more comfortable where they're already getting the majority of their OB care. So in those situations, we assess the level of safety to decide if we can care for them here at Lowry. We also do things like drug tests, urine drug screens, look into treatment, do a full biopsychosocial assessment, as well as a medical assessment, looking for liver disease and other conditions. Next slide, please.
So when patients decide that they prefer to stay in our FQHC for their obstetric and addiction care, it's usually incredibly easy because they're familiar with the providers here, they're familiar with our care team, which does include dental and behavioral health and psychiatry as well. We hit on a few points kind of from the beginning for patients. One is about the neonatal abstinence syndrome counseling. Our hospital that the vast majority of our patients deliver at kind of has a set 5-day stay, though the NAS babies are still kept in the well baby nursery. They don't go to the NICU, and I think that's probably the standard of care nationwide at this point. We do warn them that any of this drug use in pregnancy does merit a Child Protective Services report. However, as you'll see in the case, I think that doesn't always, break a relationship or result in, a negative consequence. Our obstetric team also does usually recommend a 32-week growth ultrasound just to kind of verify, that's for any patients who are still using any drugs throughout pregnancy, but also for our MAT patients on Subutex or Suboxone. We concentrate our visits so that a patient is able to see as many different of the teams in as many visits, because we all know addiction medicine and obstetrics requires so many visits throughout a pregnancy. And then really, I think our FQHC was just it was already set up to provide this type of care that it was incredibly easy. And then we're also very lucky. We're a family medicine clinic, so all of our providers here do prenatal care. And so kind of no matter who the patient sees, that we try and get them to see the same person each time. We're able to answer questions in addiction visits about obstetrics. We're able to answer, addiction questions during the obstetric visits and things like that. Next slide.
So this is just kind of a description that I like to use. If people have time, there's a great video on YouTube, and it's a Nuggets video on addiction, and it shows the cycle of addiction, and I use it with many of my patients, and it's a great way to kind of open that conversation and sometimes open the floodgates of tears, so be careful. But it is something that patients really relate to, no matter what the substance is, because if you can see from the picture, it's just this glowing yellow ball that creates curiosity, and then over time kind of darkens their world. And there are times where we get to work with patients at each and every stage of this different diagram in the cycle of addiction. So, they may be coming in at the very early stages, but we know what it looks like all the way at the end. And so sometimes, unfortunately, they don't come to us till the end. So we're hopeful that over time, with providers being educated on addiction and being more comfortable having those conversations and having someone to refer to, that we start catching our folks in the first stage or the second stage instead of waiting until they're at the end of the cycle before they make it in to see us. So we're working on barriers, of course. It's been a learning process throughout the years with confidentiality and different things, but we've all come together and work really well together. So it's definitely a great program. Next slide, please. And this is just one slide that I do like to share with my medical providers, mainly because being a patient-centered medical home, we want to make sure that we're sensitive with our language. And some of the things most commonly are dirty and clean, addict, junkie, alcoholic. Try to remove those words from your vocabulary. They're pretty old school, and a lot of patients can find offense with them. Something that's been really helpful is to kind of reflect back what they're saying to you and use the same terminology that they may be using to help them feel a little bit more comfortable. But for our case study, this was something that came in handy big time because we were met with a case where we weren't really sure what was going on and weren't getting the full story. So after having our patient get more comfortable by talking with us and knowing that we weren't casting judgment, it made things open up the conversation a lot easier. Motivational interviewing is always a huge skill that providers are taught, clinicians are taught, and can really come in handy when working with folks with an opioid use disorder or any use disorder for that matter. Next slide, please.
So this is our case, and we'll just kind of run through it. These slides have a lot of information on them. Mostly, I think, just to kind of show that, things can look really complicated, but at the end of the day, it's, if you're in a clinic that provides obstetric care and treatment for addictions, it's really nothing out of the ordinary. So this is a 31-year-old, this is her first pregnancy, comes in because she missed a period. A lot of concurrent substance use, opioids, methamphetamine, and cocaine. And then very early on in pregnancy, just kind of occasional alcohol and tobacco. She's had some intimate partner violence and legal troubles. Historically, she's a past history of ADHD, polycystic ovarian syndrome, generalized anxiety, and then, never had surgery or anything, and then just does have some legal troubles as well, is on parole for about the last, 10 or 15 years. Next slide. So this kind of goes through all of it, but basically, this case was a kind of both a stepwise approach and also a roller coaster. She stayed here at our clinic because she was within walking distance of the clinic and struggled with transportation, and so we decided that this would be a better situation. She was referred to psychiatry at that time, and she was started on Subutex with a visit with follow-up at her initial prenatal visit. Since that moment, really going throughout the whole pregnancy, she did not have a return to any use of opioids or anything that was not being prescribed from the clinic. However, she did have kind of persistent methamphetamine and cocaine use, with kind of, 2 weeks with urine with methamphetamine and cocaine, and then 2 or 3 weeks without it. Psychiatry was really helpful, I think, in giving us the comfort level to maximize the treatment of her ADHD and her anxiety. Using bupropion, which, we use sometimes in stimulant use disorder with really mixed benefits. And then also really increased her sertraline to the maximum dose for her to really try and stabilize her psychiatrically. She still was kind of persistently positive for cocaine throughout the second trimester, but we did have the first negative UTOX at around 24 weeks, which was, I know the patient was so proud about that and was really excited to share that with us. Continued to be negative, and then did have, was cocaine positive for about 2 weeks, and then really negative for about 10 weeks until just before she delivered, due to some stress with her brother who she lived with, and then she was living in a hostel with her boyfriend, who overall, the new boyfriend, who is not the father of the child, was another really positive influence. Also around the time her mom moved out here to help with things, and we did a lot of visits that her mom was here for, her boyfriend was here for, really integrating all of her support system into the medical, into the kind of our medical facility. We also do more than is probably normal. We do ultrasounds here in clinic, mostly just to build kind of a relationship between the mom and the baby as early as possible. So those aren't really necessarily medically indicated, but it is just, it's showing the movement, it's showing the heartbeat, and really being able to see that picture really increases, in my experience, the change talk of patients and how motivated they are, because sometimes people really are motivated because of the pregnancy and not because of a more external or this wasn't really on their radar moving towards sobriety. It is just because of the pregnancy, and so sometimes you're not always catching someone at the exact moment of that addiction cycle that Jessica showed. Sometimes you're kind of having to wedge yourself in where you're able, just because the pregnancy kind of pops up as a surprise. Next slide. So she delivered sober at 40 weeks. She had a little hypertension at the end, but nothing complicated. And her baby was breastfed and had the most uncomplicated neonatal abstinence course the nursery had ever seen. And that was probably because she was breastfeeding so well that baby was getting a little bit so we checked, and then really, 9 months later, still sober, still doing really well, in college to finish a degree, and baby is growing and developing normally, meeting all milestones, and is attending all appointments, and really, not everything's a success story, but this certainly was for this patient. Next slide. Thank you.
Thank you.
Thank you, Jessica and Dr. Buck, for your great presentation.
Yes, thank you so much. We now want to open it up to questions. So if you have any questions for Scott, Jessica, or Dr. Buck, please continue to type them into the chat box or the Q&A box. I will reference a question that was posed earlier in the presentation for Scott, asking if all your waivered providers are prescribing. Thank you, Scott, for answering it. I will just reiterate your answer. Scott knows out of the 22, 4 are not. We have 1 psychiatrist and 1 psych CRNP that are not just due to the need for psych services. 3 of our hospitalists just speaking data waivered. Scott, I don't know if you want to add anything else to that.
Sure. So yeah, I mean, great question. So we only have 1 part-time data waiver physician that is primarily treating people with substance use disorder and OUD. All of our other doctors are primary care doctors who are, seeing an individual with opioid use disorder and then treating a sinus infection. So we kind of, put them into the doctor's schedule. We don't have specific days that, a lot of facilities set up just their MAT day or have specific hours for that. We are open access. So, Monday through Friday, we're pretty much open access. It gets a little trickier on weekends, but we are open on weekends. So on Saturdays, we're open from 8 to 6, and on Sundays, we're open 8 to 4. If there is a need for an individual who shows up at our clinic that needs an induction, one of our Center of Excellence case managers could be called, and they could go into our clinic, which we have done many times, to do a induction in our clinic. So I would say majority of the induction work is being done Monday through Friday, but pretty much all of our shifts we have a waivered physician on. So we have it covered pretty much across the board. Like I said, our hospitalists just recently became waivered, and that is due to our new grant, and we are going to start utilizing them within the hospital system to start individuals on buprenorphine within the hospital.
Great, thank you so much. And then we did receive a question in the chat box, I believe for Jessica and Dr. Buck, but certainly Scott, if you have any thoughts, feel free to jump in. So in underserved areas, how can we work toward improved psychiatric treatment for comorbidities, for example, anxiety, for which additional medication may be appropriate?
I think that's a really important question because Jessica and I work in a really excellent healthcare system where even if a patient can't see a psychiatrist, I can always call one or message one with a case and get recommendations. And that's something that might be available in more underserved areas. But one additional thing that I have done is, as a provider, going to trainings and focusing on, observing and working in clinics where there is a high prevalence of psychiatric conditions to become more comfortable with my own prescribing of medications. And I think as a family medicine provider, that's not always a part of the training. And so making sure that providers are able to seek out those extra experiences and conferences to really improve prescribing and access. And I would say a lot of our waived physicians here also have, see so much so many psychiatric conditions that they're comfortable writing for antipsychotics, really working on second and third line anti-anxiety and antidepressant medications, treating people with comorbid conditions just because of, psychiatric care is such an under-resourced field nationwide. And so my role would be, or my advice would be really starting to empower your providers to provide a lot of that care and then know where their resources are to kind of talk through cases with people.
And then on the behavioral health side, we like to give a lot of resources. So Psychology Today and then other networks here in Colorado have database systems where we can go in with the patient, help them identify certain places that take even, the state-funded Medicaid. You can find several providers. I'm starting to see a lot of providers pop up that are offering telemedicine and different things. So always go to the internet and see if, Psychology Today has resources that are available to them in your community. Or SAMHSA also has a treatment locator, which you can get some great resources on as well, just so that you can help to find care outside of your organization if it's just not available.
Great, thank you, Jessica and Dr. Buck. Scott, did you want to add anything?
No, I mean, I think that the only thing that I would add is trying to tap into telepsychiatry. I think that the question came from an individual who's in New York. So, there are some people in New York, I know for sure, that are doing telepsychiatry. I think one of the other important things that we've done here at the Wright Center is we've really done a deep dive into our community resources to see who does exactly what do they specialize in. So we have a really large database within our referral section of our EMR that allows us to tap into individuals within our community that specialize in things that we don't. Just an example is we might deal with a patient today who is in need of some intense therapy around eating disorder. We have specialists within our community that specialize in that. But again, I'm just going to reiterate what everyone is saying is that, there is a shortage across the nation in psychiatry. And we know that this is a problem, and a lot of primary care doctors they don't have an option. They're forced to prescribe psychotropic medications to patients who are in need. So I hear you, and I think that there's a lot of work to be done around workforce development in the psych space. So yeah.
Great, thank you, Scott. And then another question came through the chat box for both our presenters. What role does Medicaid, your state Medicaid program, play in making these services possible? So Jessica, why don't we start with you? I know you chatted into the chat box, but feel free to unmute yourself and answer over the phone.
Yeah, so it's definitely a unique world, but when you provide substance use services within an FQHC, it's not necessarily considered a specialty service or substance use treatment. So Medicaid covers their treatment here within the clinic. It's when they go outside to find behavioral health services that it's a little less affordable or accessible. But at the end of the day, it's a medical visit, just like any other doctor's visits, and we let them know that they're treated exactly the same when they check in, and everything's done the same straight through the vitals. So because we have this integrated care model, Medicaid works well. It's actually the private insurance that can get really costly for our patients because the price point of Suboxone and Vivitrol is so high.
Great, thanks, Jessica. And as a follow-up to that, what about case management and wraparound services? Does Medicaid play a role in your systems related to those two items?
Yeah, so within our clinic, we have the dental office. We have WIC and a bunch of different services, and everything is accessible to them with their benefits from the state. So if they have Medicaid, they rarely have any out-of-pocket costs to be in treatment. It's when you start having the private insurance where you have deductibles and co-pays, where when you're having treatment one visit per week, it can get pretty costly in co-pays. So that's when we start to worry about our patients' financial stability. But dental, WIC, everyone works together with our patient population and the state services.
And the FQHC is so set up to do that already because we work on housing and financial issues for all of our patients.
Social work.
And we have a social worker in our clinic working on this. So we don't, so it really is no different than our other patients here.
Great, thank you both. And with that, I want to thank both of our presenters, or three of our presenters, for their wonderful presentations. If you have any questions, please feel free to email a member of the ASTHO team, and we'll be sure to field it to our panelists and provide you with an answer. And with that, I will turn it over to Natalie, who will close us out.
Thank you again, everyone, for your excellent presentations and questions. So I just wanted to highlight some next steps for the OMNI learning community. We'll be holding our next state share TA call next month, and we will be following up with additional details in the coming weeks. And as always, please don't hesitate to reach out to ASTHO staff with any of your TA requests to support the work that you all are doing in your states. With that, we can close. If you, the evaluation link was just posted into the chat box. If you have a couple of minutes to please fill it out, we appreciate your feedback so we can improve our webinars in the future. Thank you all so much for taking the time to join us today. Have a great afternoon.